I want to say that I'm very happy that we have this affiliation. I think it's been a phenomenal experience for everyone involved. Just the ability to tap into the Doheny talent to do these courses that we do is phenomenal. John, Hugo, thank you for inviting me to speak. You have a sort of tremendous marketing thing behind this meeting. I've gotten 3 emails every single day for the last 3 months, including one last night announcing that the program was going to be broadcast to the world. So I told my wife, so Kristen, if you're watching, hi. There are a lot of talks on sort of dealing with the unhappy multifocal patient, and our whole messaging in academia is sort of biased against these things. But I would like to start off this talk by saying these are phenomenal devices. Overwhelming majority of our patients are very happy with them. It's sad that most of our talks are about how to deal with the few unhappy patients. Most of them are very, very happy. But there are the occasional unhappy patients, and those are the ones that we stress about. So I'm going to kind of go through my approach to these patients. These are my financial disclosures. I don't think they're particularly relevant. So what does the happy multifocal patient look like to start with? It's pretty simple. They've had uncomplicated surgery. They have good uncorrected distance and near visual acuity in both eyes. They have good visual quality, which is more than just visual acuity. And they have no binocular vision disturbance. So a pretty simple recipe. It's important to know, as I kind of hinted, that despite all the papers and presentations to the contrary, the overwhelming majority of these patients implanted with multifocals in both eyes are very happy with them. It's a very small group that are unhappy. So what makes for an unhappy patient? Well, clearly, any patient has surgical complications is likely to end up in this bin. Poor uncorrected distance or near visual acuity in either or both eyes. Poor visual quality, or any binocular vision disturbance. Essentially, if they're going to need prisms to cut to the chase on this one, why implant a multifocal? They're going to be in glasses. These patients are wanting spectacle independence. I have found over my years of doing this that non-predictors of multifocal IOL satisfaction are personality type and occupation. We used to obsess about the engineer, the truck driver, the airplane pilot, type A personalities, engineering personalities. You don't want to touch these people with the multifocal, and I've found they're just like everybody else. If you get a good refractive result on these patients, and they don't have these problems that we've talked about, even the most stressed out, hyper type A engineering personalities will be very, very happy with these lenses. I think in order to present these lenses properly to patients, because they need to understand the compromises of these, you need to know about the lenses. So there are 3 basic types of lenses on the market throughout the world. There are zonal refractive lenses, which have kind of fallen by the wayside, full diffractive optic lenses, and diffractive refractive. The full diffractives come in bifocal and trifocal varieties around the world. In the US, currently, we don't have a trifocal variant. So the prototypical zonal refractive lens was the AMO array lens, which then was replaced by the resume lens. And this has concentric rings. Each of them is focused to one or the other, the distance or near. These are pupil size dependent, and these transition zones between the rings produce significant halos around lights. And these have kind of gone by the wayside, although I think the resume is perhaps still sold for patients who have had it implanted in the first eye. The 3M lens is evolved into was a prototypical full diffractive. I think the most common that we have in our experience now is the AMO Technis multifocal. So it's a full diffractive optic all the way out to the 6 millimeter diameter. It is not pupil size dependent. And then we have the diffractive refractive, and the prototypical device here is the Alcon Restore lens. The central 3.6 millimeters of this optic is diffractive, and everything from that ring out to the periphery is refractive set for distance. And this lens, of course, is pupil size dependent. So all these devices have some visual compromise that we throw at the patient. And it's important for you to convey to patients what those visual compromises are. So they're giving up something to get something. So what they're getting is reading vision without having to go to reading glasses and without having to go to monovision. And what they're giving up is on this list. So they're going to experience some reduction in contrast sensitivity. I think, fortunately, the visual system is pretty good at contrast enhancement. And so most patients don't perceive this reduction in contrast. In fact, you're taking out their cataract, so they're gaining a bump in contrast. And so the degradation of contrast due to the lens is really not appreciated. They have halos around point sources of light, particularly at night. These are very common and prevalent in the first month or two. When I see patients back a year, 2 years later, there are no spontaneous complaints about halos. Maybe it's like living next to the freeway, you just get used to it. But I think it's less, I think it's actually more than that. I think they actually don't appreciate it because this just doesn't bother them. With certain models of lenses, like the Restore lens, there's difficulty reading under low light conditions. And then there are optical aberrations, as with any aspheric lens, if the lens is not perfectly centered in the pupil. That central ring of the multifocal needs to be inside the pupil if the patient's going to have good quality vision. If that central ring is splitting the pupil or outside the pupil, the patient will have problems. So what does the ideal multifocal candidate look like? It's pretty simple. They want spectacle independence. And I tell every single patient, we're not going to get you out of glasses. You will still be wearing sunglasses. You will occasionally be wearing reading glasses if the light's low, even with the full diffractive optic. I also tell them, I'm not God. I can't guarantee a perfect distance vision result, and you still may need glasses for driving at night or some activities, but most of your day will be relatively free of spectacles, even if I don't nail it. So they're looking for relative spectacle independence. They understand the limitations of the technology because you've done some explaining it to them. They can afford the cost, and they have no ocular comorbidity. Now that last one is really important. They really need to have no ocular comorbidity, or at least no vision limiting ocular comorbidity. It bugs me when I go to meetings and I hear people at the podium saying, you know, like 85% of my patients receive multifocals. I think those practitioners are not screening their patients well enough for these comorbidities. 60 to 65% of the patients in my binocularly sighted practice have one or more ocular comorbidities. So they're very, very common in our cataract patients. So these are contraindications to multifocal implantation. So vision limiting ocular comorbidity in either eye. I will not implant a multifocal if the patient has a monofocal in the fellow eye. I think you need the summation effect, especially at near. If they have high amounts of astigmatism in either eye, unless you live in a country where you have a toric multifocal that can handle that, I'm not quite sure when these are going to finally make it through the FDA approval process here, hopefully later this year, early next year. If they have any significant amount of irregular astigmatism or high order aberrations, I currently don't implant patients with a history of keratorefractive surgery with multifocals. And then I have this bucket of potentially problematic conditions in either eye. And an example of that would be somebody who has a progressive zonulopathy where the lens may be perfectly centered in the pupil today or tomorrow, but a year from now or 2 years now, it might drift off. So those patients, I think, should not be implanted. And as I mentioned earlier, any binocular vision disturbance. So ocular comorbidities, there's just a bazillion of them. You can basically put them into the anterior segment of the eye or into the posterior segment of the eye. And this is just a small scattering of the types of things, and we do whole talks on just comorbidities to avoid. If you think you can treat the comorbidities, do it ahead of time. Don't do it after the implant's in the eye. So what can you do to reduce the risk of ending up with an unhappy patient? Again, pretty simple. Avoid implanting those with the contraindications that I just mentioned. Take care in your optical biometry. Well, we do this for every single patient, so we're not doing anything special for these patients. Take care in managing corneal astigmatism. You as the surgeon, that's probably your primary, other than sort of ruling out these comorbidities, is your primary responsibility as a surgeon is to make sure their astigmatism after surgery is very good. For a multifocal, if you can nail the spherical equivalent, so the spherical equivalent refraction is 0 diopters, you need to have that astigmatism down to within 0.75 diopters. And if you don't nail the spherical equivalent, if you're off by a quarter or a half, then you have to have even a tighter band around your corneal astigmatism. Take care of in handling these lenses in the operating room. You can't manhandle these lenses. These are diffractive optics. They're bending incoming wavelengths of light, waves of light to a half a wavelength. So if the lens is distorted, toric, damaged, pushed on, it will not perform. So I tell the scrub techs, never touch the optic. Leave the lens in the loading bay of the injector. Don't advance it down to the nose cone and then just leave it on the operating table for 10 minutes. And then you, as a surgeon, need to make sure that that central ring is positioned in the middle of the pupil. And if you have access to an intraoperative aberrometer, I think that's probably a good idea. So what do you do once you find yourself in trouble? No, occasionally you will. These are my pearls for handling the unhappy patient. The first thing is don't abandon the patient if he or she is unhappy. Second is figure out what the problem is. Thirdly, fix the problem if you can before moving on to surgery in the second eye. Don't sweep the first eye under the carpet by making them forget what normal's like. And number 4, don't mix and match lenses when you implant the second eye. So number 1, don't abandon the patient. Patient's going to be unhappy. They're going to be basically pointing the finger at us. They're going to blame us overtly or subtly for the problems that they're having. And the reality is, at times, you will be at fault for not doing a good job. So your natural instinct is going to be to go on the defensive and then start to try to get the patient out of the office really fast so they don't disturb the others in the waiting room. And this is where you have to just slow down and take a few punches, let it kind of absorb it, and then move on. But don't immediately go on the defensive. You have to put yourself in their position. They're afraid, they're frustrated, and they're basically looking to you for assurance that in the end everything's going to be all right. And so you need to assure them that you're going to do everything in your power to sort out the problem and then fix it if you can't. They realize you're not God, you don't have full control, but they want to know that you're vested and you're going to do what you can to make sure that the final result's a good result. And they also want to know that you've seen this problem before, like, oh, I've never seen this one before. No, they don't want to hear that. They want to hear, oh, I've seen this a dozen times, and this is what we're going to do. This is our game plan. Yep, passed over. So most of the time, it's just a refractive error. And sometimes it'll be an anterior segment comorbidity. Sometimes it'll be a posterior segment comorbidity. And then sometimes it's going to be at the lens plane. It's going to be the capsule of the lens. It's going to be the lens itself. But figure out what it is and deal with that problem. And these are just a short list of the comorbidities. Dry eyes, generally easily treated. Corneal astigmatism, we can treat that. Basement membrane disease, corneal scarring, get a bit of a problem there. Prior refractive surgery. We can fix a lot of these problems even after lenses in the eye. Correct refractive errors with glasses, contact lenses, IOL exchange, piggyback lens, or whatever. Any one of these refractive procedures. Treat comorbidities that can be treated. Call in the troops if you need to. If it's of an epiretinal membrane, call in your retina colleagues. If there's no obvious refractive error and no obvious comorbidity in the anterior or posterior segments, and especially if the quality of the near vision is is poor, it might be the lens itself, and you have to think about a multifocal lens exchange. Maybe your lens was damaged in the operating room. It helps if a wavefront map can pin the problems on the lens with lots of high-order aberrations. I am not a believer, never have been, a believer in mixing and matching lenses. I think multifocal lenses work best if there's binocular summation at distance and at near, so I don't like to position near focus at different points. You don't get optimal summation if you do that. Patients also are always going to prefer one eye over the other if you position the near point. And they're going to kind of blame you or blame the lens for the poor quality of the one that they don't like. So if you just don't open up that door for them. So in summarizing, don't abandon your patient if he or she is unhappy. Figure out what the problem is. Fix the problem if you can before moving on to surgery in the second eye. And don't mix and match lenses. Thank you very much.